Greetings from eMedi News and Heart Care Foundation of India. Welcome to the show, Chat with Dr. KK. Today we are going to have a chat with Professor Dr. VK Bahel, who is Head of Department of Cardiology at All India Institute of Medical Sciences. He has also been the past president of Cardiological Society of India, and this year he has also received Dr. V.V. Shah oration on evolution of management of acute heart attack. That's what oration he has given. Congratulations for the oration.
Thank you for inviting me to this show.
And let me just tell me in a couple of sentences about the key points of your oration.
See, leave apart the development in the management issues, which, as we know, the primary angioplasty is available, thrombolytics are available, host of antiplatelets starting from aspirin to clopidogrel to ticagrelor to bivalirudin to glycoprotein are available, which we know. The smaller nuisances like radial approach may be better than femoral approach, or a culprit vessel angioplasty in a stage may be better than multi-vessel, or that means open the artery which is causing the heart attack during that primary angioplasty. There are a lot of research on stem cell. There is a lot of research on different types of stents which are being used. There are different type of thrombectomy devices, because we know the coronary thrombus occludes the artery. So if we can take rid of this thrombus by aspirating or mechanical devices, that may do good. Future research is going to be on preventing reperfusion injuries. We open the artery, we reperfuse the myocardium. That saves 50% of the myocardium scar. If we can prevent the reperfusion injury, every good thing comes with a bad thing. No, reperfusion injury happens once you open the artery, the myocardial permeability pores open up, and this leads to sudden influx of calcium and toxic radical oxidants, which kill the myocardium and leads to apoptosis or so-called cell death. If we can prevent this by conditioning the heart, so-called remote conditioning, or some pharmacological agents, which will be the future.
What are the options available to prevent
like a simple technique of, if you are wheeling the patient to, say, from home to in ambulance, if you inflate the blood pressure cuff for 5 minutes, deflate it for 5 minutes, do this for 4 cycles, it is called remote preconditioning. This simple technique has been shown that you can prevent additional scars.
So let me spend some time on remote reconditioning.
Okay.
Remote reconditioning basically is equivalent to what we do a flow mediated dilatation of brachial artery. The same extension of that. So if I have to do that, people say you can reduce contrast nephropathy if you do a remote reconditioning. You can improve the circulation of that. So first of all, let me exactly narrate the procedure. That you take a cuff, put it into the arm, inflate it
5 minutes,
above the size of systolic blood pressure, and then deflate it, and then do it.
We used to do the same thing for coronary arteries. Occlude, declude. It's seen the first time you occlude, there is more ischemia. When you repeatedly do this, there is less ischemia. But what they have found is, in the body you produce ischemia in any organs, it is also translated to the myocardium. So that's a good
thing. It will improve the renal circulation.
But this is small trials. We are not into. But this.
I just want to go further into it. Can it be used as a routine?
No harm. It's a simple innocuous patient.
In a patient who has a coronary artery disease, who is refractory to treatment, refusing surgery,
then you are going to a different dimension. That is in the peripheral arteries. You do what is called EECP. That's a different technique. Here we are talking of small reduction in ST resolution, small reduction in scar tissue. Same conditioning of the heart you can achieve by giving some pharmacological agent like colchicine, like adenosine, like nicorandil. Many of them have failed. Many of them are coming up. A lot of research is going on. So what I mean is, you have achieved now reperfusion. Everyone knows it should be done early, golden hour concept, angioplasty if possible, take the patient to wheel in a cath lab. This concept is now well established. We can discuss the logistics of that in Indian context. But now major reduction in mortality will come by preventing this reperfusion injury and regenerating the myocardium. How we can regenerate stem cell?
Remote reconditioning, you're doing it before the angioplasty, after the angioplasty? Before the angioplasty. And 4 cycles?
And people also have done the conditioning, post-conditioning also, but then they didn't find. There will be
research. It's a pre-procedure, pre-conditioning, 4 procedures, 4 times. 5 minutes, and then gap of 5 minutes, and again 5 minutes.
Definitely. Yes.
with that.
Yes.
And is there any trial available in your
Yes, it is.
institution? In your institution?
No, we have not started because unfortunately, like as I was telling you, logistics, we don't wheel in the patient from the home to the they come to our door. So our role starts when he comes to door. This delay in heart attack is at 4 levels. One is diagnosis. Most of patients think it's gas and the acidity. So there is first delay on the part of patient. We have to educate him to reduce this delay. Then is door. He has to reach from diagnosis to door, and you know the state of affairs in the traffic and all that, and ambulance not available, patient has to come in his own vehicle, so there will be the second delay. From door to delivery, that's the third delay, third D. Because patient reports to an emergency, there is no dedicated heart attack centers like trauma centers, which will save more lives, paradoxically, I can tell you. So if a patient has a chest pain, he is wheeled into a heart attack center, given a thrombolysis, you will save all the time. Here he goes to an emergency center where patient of malaria is there, diarrhea is there. Till his time come for triage, he is losing time. Every minute is important. The question will be, once door to delivery time is in my hand, I can improve my hospital system to reduce that. Diagnosis to door is in the government hand because they can provide the ambulance services, they can provide the facilitation for the ambulances to go in a smooth way, and that. So these are the delays which we know. But if you talk scientifically, which will be the next surge will be in preventing those reperfusion injuries and having half the damage, because some damage will occur, reducing the scar and increasing the viable myocardium. How that will happen? By the stem cells. Lot of promise. Till day, I can't say it is in clinical realm. There have been 33 trials which have a six-year follow-up. That means it's a lot of interest. But we have not found the right cell. We are taking the cell from bone marrow. We are taking it. Now the next step is to find out the right cell, which is called cardiosphere-derived cells, taken by endomyocardial biopsy from the heart, and these stem cells are manufactured from that biopsy tissue and injected into intracoronary after 4 weeks or 3 weeks. Second is, when you do bypass, you take out the right atrial appendage, which is a vestigial circuit, and make stem cells. So there are a lot of research on myocardial regeneration. These are the two future. Now you have to talk of logistics as a reality. This was what is.
I'll come back to something else.
Yes.
So we talk about ideal situations, but do my 90% of the people
Yes.
can
Very,
afford it?
very,
That's one. And
very
two, are they really getting all this what they are getting,
Yeah.
what they are supposed to get?
Yeah, affording is a very comparative term, so I won't go into the affording
But
part first. Let us go to logistics.
There's a difference between a standard of care and a magnitude of care. The
Yes.
magnitude of care may differ, but the
Yes.
standard of care should be the same.
You are-
that means if I get a heart attack in a rural area,
You are
I
absolutely
must get the same treatment.
You are absolutely right that we have to bridge this gap, that a minimum care is available irrespective of the location of the patient. As you rightly said, in rural area we may have nothing, but in cities like Delhi, you may have best of the care available to the world if individually. But we have to bridge this gap between so-called Bharat and India. And for this, all stakeholders, be they physician, be they voluntary organization, be they corporate hospitals, be they industry, be it public at large, be it government, they all have to put their efforts so that these delays can be reduced. Now, the second part is, then we have to set our standard of so-called cost effectiveness. Suppose I say the primary angioplasty in the trials have been shown to be better than thrombolysis. That does not mean that if you cannot do a stenting, you should not do a thrombolysis. Because if you do a thrombolysis, you will save lives, you will reduce the scar. Maybe it is to a less magnitude as compared to stents. So that's where the question of minimum care comes. Okay, I cannot afford a drug-eluting stent in all patients of myocardial infarction, but I can afford a bare metal stent. Go ahead and do that. I cannot afford a bare metal stent, but I can afford a balloon. So do a plain balloon angioplasty. This will be better than doing a thrombolysis. You can't afford any angioplasty, do a thrombolysis. Thrombolysis, fibrin-specific agents will be better. You can't afford it, give streptokinase. Streptokinase is very cheap. It can be afforded by all with our healthcare standards. It can be given free of cost to any person who's coming to, even in All India Institute. If a person comes with myocardial infarction, we give him streptokinase as a minimum treatment. So those are the things which we have to see. You will be surprised, or you must be knowing That Kerala chapter of Cardiological Society of India has done a beautiful registry called ACS registry, and they have published it in European Heart Journal, a 25,000 patient registry. The data at the least, if I put it mildly, are worrying. 1/5 of the patient in that registry, this is coming from a state which has the lowest infant mortality rate, which is the highest literacy rate, which has one of the longest life expectancy rate. 1/5 of the patient received thrombolysis wrongly in patients of non-ST elevation myocardial infarction. Half of the patient did not reach within 60 minutes of chest pain to the hospital, which is the standard recommended. 1/3 of the patient did not get thrombolysis. That means door to bulb needle time was more than 30%. Half of the patients only received thrombolysis, other half did not receive it for some reasons. Only 13% of the patients received primary angioplasty. Only half of the patients received the so-called recommended drugs of beta blockers, ACE inhibitors, and statins. This is coming from a state of
Maximum literacy. And what will happen to the
what
states?
do they say? So these simple measures can reduce the myocardial infarction rate of mortality in society. We are talking of individual care. Yes, best of the care is available in India. There is no doubt about it. Whatever is available in the West is available in India. But is it available to all? Definitely a big no.
Okay, go away from the oration and
Yes.
oration topic and general topic. What are your hobbies?
Very different. I no such hobbies like general sort of
That means
things.
if you would not have been a doctor, what you
Yes.
would have become?
Difficult question. Do I have to think what would I have become? See, I will say from very beginning, I used to look upon doctors as something I should achieve. I studied in Allahabad, so we did not have a good library. When I did my MD for thesis, I had to come to National Medical Libraries to see the journals, and I stayed here for 15 days. At that time, I used to see All India Institute of Medical Science, and I always used to aspire, can I enter this building? I entered that, and I became head of the department. So all my thought processes are only in the field of medical sciences. Surprisingly,
So you
I
never
never
thought
thought
of
of
anything else.
anything else.
Okay, if you are the health minister of the country for a day, what changes you will bring in cardiovascular prevention program?
If I'm in a day and that happens to be
With full power.
yes, with the that happens to be budget day, I will increase the health ministry budget to at least 2.5 of GDP, which is at least 1.6 to 1.9
So you
now
will increase the budget.
and then start providing, looking after the what can we offer to all. As I say, minimal standard of care. I am an advocate of cost effectiveness. Trial may have shown after a heart attack, if ejection fraction or LV function is low, you should receive ICD. But I do not offer these my patients whom apparently I look cannot afford, because if I tell him that this is a device, if you apply, he thinks that he has not got the best treatment. So I do not, if even if I have to speak not the whole truth, I will not
You
offer.
behave like Krishna and not Ram.
Maybe you can tell, but
Because Krishna was the one who told you.
I think every one of us should do that. Because hope is very important for the patient. We the negative thoughts patient doesn't want to see. He also knows he has a heart attack, he may die. But if I can give him a glimmer of hope that okay, you do, like they used to say when exercise came for patients of coronary artery disease, that there is a big list of no's. Don't smoke, don't drink, maybe don't take non-veg diet or high fat diet. Don't, so many don'ts were there. Don't eat ice cream, don't do this, don't that. Exercise came as a positive thing. Do walk,
Do this, do
do
walk.
walk. So patient has something to look forward to. He has enough of negative, so those small things happen.
So my last thing is that cardiopulmonary resuscitation today has become simple. Hands only CPR, no mouth to mouth
Yes,
resuscitation.
yes,
Do you feel that it should be advocated at a big level in the country?
no doubt
With
about
25 lakh people dying every year?
No doubt about it. See, but see, we are far. We are talking of. You are talking of. We have so many basics things to take care of. Like what prevents a hospital from having a heart attack center? You have to just designate an area where all patients of chest pain are coming with the same facilities. But there are so many things you have to look after. These are bigger society challenge. Who tells you what are there are channels now which are showing medical programs. What are the symptoms of heart attack? Most of the people still, even in cities, think, no, gas, this will vanish, and you have lost the time. So there are many small things. A tablet of aspirin, say a tablet of aspirin, reduces mortality as much as streptokinase does. I'm not saying don't combine the two, but I'm giving you example. So have patients been told just take a chewable tablet of aspirin?
So what Dr. Behel has said is that the basic awareness which can be created in the community is that if you're suspecting a heart attack, chew a tablet of 300 milligram aspirin. It is as good as giving a clot dissolving therapy. If you cannot give a clot dissolving therapy, you must give an aspirin. Even if you want to give a clot dissolving therapy, it has to be preceded by a chewable aspirin.
I'll say give both, but
yes,
at least
obviously both. So we thank our guest, Dr. Behel, for joining us in the show.
Thank you for inviting
and
me.
that's all for today. We'll come back with one more show. Till that, goodbye. Thank you.